I want you to do something with me right now. Just take a deep breath in.
Hold it for a second.
Yeah, hold it.
Yeah.
And then just let it out. Breathing is totally automatic, isn't it? It just happens in the background of your life.
Right, until it doesn't.
Exactly, until the very act of just exhaling becomes this conscious, exhausting effort.
It's really the ultimate inventable privilege, you know? We don't think about our lungs at all until the microscopic architecture inside them starts to fail.
And by the time we actually notice that failure, the damage is, well, it's already profound.
It really is.
And that reality is exactly what we're focusing on today. We have this massive stack of sources in front of us: medical histories, pathophysiological research, global clinical guidelines, and it's all zeroing in on COPD.
Chronic obstructive pulmonary disease.
Right. And our mission for this deep dive isn't just to, recite a list of symptoms. We really want to look under the hood of the lungs.
Yeah, we need to dismantle this common misconception that COPD is just some mild smoker's cough. Because it's not. I mean, we're looking at a progressive structural destruction of human anatomy.
Okay, let's unpack this, because the definition of what we're actually talking about here has shifted wildly over the years.
Oh, absolutely. It's been a moving target.
Yeah, like if you look at the current standard, which comes from the 1997 Global Initiative for Chronic Obstructive Lung Disease, or GOLD, they define COPD as a common, preventable, and treatable disease.
Right.
And the hallmark is persistent airflow limitation. But reading through the medical history, it's super clear that COPD isn't just one single disease.
No, not at all. It's an umbrella term.
Yeah.
It covers two overlapping pathological processes, which are emphysema and chronic bronchitis.
And historically, the medical community treated those as completely separate things, right?
They did, yeah, for a long time. The big conceptual leap was realizing that most patients actually have a mixture of both happening at the exact same time.
The history of how we figured that out is just fascinating to me. Like, the word emphysema actually comes from the Greek word emphazon, which means to inflate or to blow into.
Which is very fitting.
Right. And way back in 1819, this French physician, René Laennec, the guy who literally invented the stethoscope, by the way.
Talk about a legacy.
Seriously, he used his new wooden listening tube to hear these hyper-resonant, hollow chest sounds. And he correlated those sounds with overinflated, air-trapping lungs that he found during autopsies.
So he proved emphysema was a structural, anatomical problem.
Exactly. And meanwhile, on the other side, you had bronchitis, which is a term coined in 1808 by Charles Babbage, but that was diagnosed purely on symptoms.
Right. If you had a chronic cough and you produced mucus, you had bronchitis.
Boom, diagnosed. And those two concepts ran on parallel tracks for over a century.
Until 1959.
The SIBA Guest Symposium in London.
Yes, a landmark moment.
Yeah.
That's when scientists finally sat down and formally grouped these separate issues into one unified syndrome of airflow obstruction.
But even today, the diagnostic boundaries aren't totally settled, are they?
Well, no. The standard test is spirometry, where you basically blow into a machine. And doctors look at a fixed mathematical ratio, which is FEV1 divided by FVC.
And for anyone unfamiliar with the acronyms, FVC is forced vital capacity, right? Like the total volume of air you can possibly exhale.
Exactly. And FEV1 is how much of that air you can force out in the very first second.
Got it.
So for decades, the rule was just if your FEV1 is less than 70% of your total capacity, you have COPD.
But there's pushback on that now.
Yeah, a lot of critics point out that this rigid number overdiagnoses the disease in the elderly.
Because older lungs naturally lose elasticity anyway.
Right, just with normal aging. And on the flip side, it underdiagnoses it in younger people, which is why there's this major push now to use a lower limit of normal metric instead, which adjusts for age, height, and sex.
It really highlights just how complex this disease is to pin down, even now in 2026.
It definitely does.
But here's what I always get hung up on. For the longest time, doctors just blamed old lungs and smoke exposure.
Just, yeah, wear and tear.
Right. So how do you go from René Laennec listening through a hollow wooden tube in the 1800s to actually understanding the cellular chemistry of why the lungs are falling apart?
What's fascinating here is that the breakthrough into the actual biology was a total accident.
Really? An accident?
Yeah. It was 1963 in Malmö, Sweden. Two researchers named Carl Bertil Laurel and Sten Eriksson were running routine blood protein tests.
Just doing the daily lab grind.
Exactly. They were using protein electrophoresis to separate blood proteins by size and charge, just processing hundreds of random patient samples. And then they noticed an anomaly.
Oh, I love a good lab anomaly.
Right. And a small subset of these samples, a specific protein band, the alpha-1 band, was completely missing.
Just gone.
Just gone. So doing what good scientists do, they pulled the patient charts to see who these samples actually belong to. And they discovered that the individuals with this missing protein had a shockingly high rate of early onset emphysema.
Oh, wow.
We are talking about people in their 30s and 40s, sometimes with absolutely zero history of smoking.
Wait, I need to stop you there. If this protein is missing from their blood, why is the destruction isolated to their lungs? Like, why isn't this enzyme digesting their skin or their muscles?
That is the critical question. And it comes down to the fact that the lungs are unique because they are constantly exposed to the outside environment.
Oh, right. You're literally breathing the outside world in.
Exactly. With every single breath, you draw in microscopic particles, bacteria, pollutants. So to deal with that constant influx, the lungs maintain a high baseline population of immune cells, specifically neutrophils and macrophages.
Basically, the microscopic bouncers.
Right. And when those immune cells encounter an irritant, they release an enzyme called neutrophil elastase to destroy pathogens and clear out dead tissue.
Okay, so elastase is the weapon.
Yes. Now, in a healthy person, a protein made in the liver called alpha-1 antitrypsin, or AAT, circulates to the blood, enters the lungs, and neutralizes any excess elastase so it doesn't damage the healthy tissue.
So AAT is the peacekeeper protein.
Precisely. And what the Swedish researchers stumbled onto was a genetic condition where the liver produces defective AAT. It basically gets stuck in the liver and never actually reaches the lungs.
So without the peacekeeper, the elastase in the lungs just runs wild.
It runs wild and literally digests the lung tissue itself.
That is wild.
It was a massive natural experiment. It proved that a single missing protein could mimic the exact same lung destruction usually blamed on decades of smoking. It entirely shifted the paradigm.
Because emphysema was no longer just about aging.
Exactly. It was now understood as a protein-antiprotease imbalance.
I love that phrase so much. It perfectly sets up the microscopic war happening inside the chest. Because when we talk about typical smoking-induced COPD, it's really two fronts of a war, the plumbing problem and the structural problem.
Yes. Let's start with the plumbing, which is chronic bronchitis.
Okay.
The timeline of that airway destruction is just staggering. When someone inhales cigarette smoke or, severe irritants, it chronically inflames the bronchioles. The body basically panics and tries to protect itself by ramping up mucus production.
Like it's trying to trap the bad stuff.
Right. So the goblet cells and submucosal glands physically enlarge and multiply. Pathologists even have a specific metric for this called the Reed index.
Which measures how thick these mucus glands get, right?
Yeah.
Compared to the airway wall itself.
Exactly. And while the body is pumping out all this extra mucus, the smoke is actively destroying the cilia.
Those are the tiny, hair-like sweeping structures.
Right. They normally push the mucus up and out of the lungs.
It's a terrifying mechanical failure, honestly. I mean, think about it like trying to water your garden. It's like a metal pipe where this thick, sticky mineral scale is rapidly building up on the inside, drastically narrowing the tunnel.
Yeah, that's a great visual.
And at the exact same time, the outer casing of the pipe itself is becoming rigidly scarred from chronic inflammation. The mucus pools, it breeds bacteria, and the airway just chokes itself off.
It really does. But as devastating as those narrowed, clogged pipes are, the emphysema side, the structural problem is where the lung architecture truly collapses.
And this circles right back to that anti-protease imbalance we were just talking about.
Exactly. Smoking creates a chemical double whammy in the lungs. First, the smoke draws a massive army of those elastase-releasing immune cells into the lung, which creates a flood of destructive enzymes.
Right.
Second, the chemical oxidants in the cigarette smoke directly attack the AAT peacekeeper protein.
Wait, so the smoke doesn't just increase the attackers, it actively disarms the defenders.
That's exactly what it does.
How does it physically do that, though?
So the oxidants in the smoke target a critical methionine residue on the AAT protein. To visualize it, think of the AAT protein as a highly specific metal key that fits perfectly into the lock of the elastase enzyme to shut it down. The cigarette smoke acts like battery acid sprayed on that key. It oxidizes the metal, rusting it and changing its shape just enough that it can no longer fit the lock.
Wow, so the immune system just goes completely rogue.
Totally rogue. Without the AAT protein able to neutralize it, this elastase enzyme just digests the elastin scaffolding of the lung.
The elastin, that's what makes the lungs stretchy.
Right. So the tiny grape-like air sacs, the alveoli, They lose their wall. They merge into these large, floppy, useless air spaces, destroying the surface area you need to exchange oxygen into the blood.
Which creates this devastating mechanical consequence because that elastin scaffolding is what gives the lungs their elastic recoil.
Yes.
Without that outward rubber band tug pulling the airways open, those small airways just collapse prematurely the very second a person tries to breathe out.
And that right there reveals the core truth of COPD.
Yeah.
It is fundamentally an expiratory problem.
Meaning you can get the air in, but because the tissue is floppy and the pipes are scarred, you trap the air trying to get it out. Your chest actually barrel expands over time because you're constantly trapping stale air. So you have air trapped behind these clogged pipes inside tissue that has lost its rubber band snap. What happens to a person over a lifetime with this? Like, how fast does this decline?
To understand that trajectory, we look to a landmark study by Charles Fletcher and Richard Peto. It ran from 1961 to 1976.
A long study.
Very. They tracked about 800 working men in London over 8 years, repeatedly measuring their FEV1 to map out exactly how fast lung function is lost.
And it turns out healthy non-smokers naturally lose about 25 to 30 milliliters of FEV1 capacity every single year, just from normal aging.
Right. But susceptible smokers, they were losing it 2 to 3 times faster, dropping up to 150 milliliters a year.
That data is sobering because it forces us to confront this really common and frankly dangerous
Myth. Oh, I know the one you mean.
Yeah, I hear this constantly. People assume, well, I'll smoke now, and when I finally quit, my lungs will just clean themselves out and go back to normal. Wait, so if someone listening to this quits smoking today, their lungs don't actually heal. They don't get that lost capacity back.
It is a really harsh truth, but no. Quitting smoking is absolutely the single most important intervention, but it's really about stopping the bleeding.
Okay, so it halts the damage.
Right. When a smoker quits, their accelerated rate of lung decline slows down and returns to the normal, gentler slope of a non-smoker's aging lung. But the Fletcher-Peto curve proved that the lung function you've already lost, the alveoli that were digested by elastase, is gone for good.
The damage is permanent.
Yes. You cannot reverse the alveolar destruction or restore the lost elastic recoil.
Wow. You are basically permanently resetting your baseline, and you just have to live with whatever capacity you have left.
Which is exactly why early intervention is critical. Because the damage is permanent, physicians essentially have to become detectives. They rely on high-resolution imaging to map out exactly where the destruction is, because the physical location tells a story about what caused it.
Yeah, I was reading about these anatomic patterns, and it makes total sense mechanically. Like, if the destruction is clustered in the upper lobes of the lungs, what they call sensory acinar emphysema, that points a giant neon finger at smoke inhalation.
Yep. Because inhaled smoke particles are light, so they naturally rise and deposit preferentially in the upper lobes.
Makes sense. But conversely, if the imaging shows panacinar emphysema, which is uniform destruction spread throughout the lower lobes, that points to the genetic alpha-1 antitrypsin deficiency we discussed earlier.
Right, the people missing the peacekeeper protein.
I noticed the sources specifically mention the PZ genotype for this. What does that actually mean?
The letters just refer to the specific genetic coding. So P stands for the protein, and Z is the mutated version of the gene.
Okay.
Everyone inherits 2 copies, so if you have the PZ genotype, you inherited the severe mutation from both parents, meaning your liver is making almost entirely defective AAT. And this accounts for about 1 to 3% of all COPD cases. So identifying it early is vital. Unlike smoking-related COPD, this genetic form actually has a specific therapy.
Oh, really?
Yeah, you can give the patient an intravenous infusion of pooled human AAT protein to artificially replace what they're missing.
See, mapping the anatomy is just so much more useful than relying on the old medical stereotypes.
Oh, don't get me started on the stereotypes.
Right. For most of the 20th century, doctors casually labeled patients with these catchy, almost cartoonish bedside mnemonics. You had the blue bloaters, the chronic bronchitis patients who were cyanotic, holding fluid and straining their hearts.
Yes.
And then the pick puffers, the emphysema patients who are thin, hyperventilating to compensate, but maintaining a pink complexion.
Those mnemonics are a classic example of medical oversimplification. I mean, modern imaging proves that real human beings rarely fit cleanly into those boxes.
You usually have a mix.
Exactly. Most patients have a blended phenotype, and relying on tidy stereotypes frequently delays recognizing mixed presentations of the disease.
Now, here's where it gets really interesting, though. When we talk about treating this permanent destruction, There's a surgical option that sounds completely paradoxical to me.
The NET trial.
Yes, the National Emphysema Treatment Trial from the late 90s, they literally cut out pieces of a patient's lung.
They do.
How on earth does physically cutting out pieces of a patient's lung make them breathe better? I mean, less lungs should mean less capacity, right?
On the surface, I completely agree. It sounds totally counterintuitive. But if we connect this to the bigger picture of chest mechanics, it actually makes perfect sense.
Okay, lay it on me.
So remember, the lung is hyperinflated with trapped air inside useless, floppy, destroyed tissue.
Right.
That dead tissue acts like a permanently inflated balloon, taking up physical space in the rigid box of the chest cavity. It literally crushes the remaining healthier lung tissue and pushes the diaphragm down into a flat, mechanically useless position.
Oh, so it's a real estate problem.
That is exactly it. By surgically removing the most hyperinflated, dead upper portions of the lung, you free up space in the chest cavity.
And that lets the diaphragm move again.
Yes, the diaphragm can curve back up into its normal dome-like shape, which allows it to contract efficiently again. And the remaining healthier lung tissue now actually has room to expand and function.
That is just brilliant engineering.
It is brilliant, but NET also revealed a really sobering reality.
What's that?
Well, for patients who had the right pattern of upper lobe disease, it worked wonders. But for patients who had diffuse disease spread everywhere and very low baseline FEV1 scores, this exact same surgery actually increased mortality.
Wait, it killed them?
It killed them.
Meaning you can't just apply a blanket treatment. Precise phenotyping is literally a matter of life and death.
Absolutely. And this need for precision brings us to a massive global blind spot regarding who actually gets COPD in the first place.
Right, the myth that it's exclusively a smoker's disease.
Yeah.
If you look at the data globally, that is just completely false.
The World Health Organization has been sounding the alarm on this for years, actually. A leading cause of COPD worldwide is indoor household air pollution.
We're talking about burning biomass fuels, right? Like wood, animal dung, crop residue for cooking and heating inside poorly ventilated homes.
Exactly, which means this disease is heavily impacting non-smoking women in low- and middle-income countries who have never even touched a cigarette in their lives.
That's heartbreaking. The severe smoke exposure is coming from their daily survival, literally just from cooking dinner for their families.
It is, and this raises an important question about how we fundamentally define the origins of the disease. In fact, there was a fierce scientific feud in the 1960s about this very concept, the British hypothesis versus the Dutch hypothesis.
Oh, the scientific feuds are always the best part.
They are.
So the British, led by Fletcher, basically argued that COPD was a straight line driven by the environment. You smoke cigarettes or you breathe in biomass smoke, your airways get irritated, you develop bronchitis, you develop emphysema. Simple cause and effect.
Right. But the Dutch, led by Nicholas Ory, proposed a much more complex web. They argued that there's an underlying genetic predisposition toward airway hyperresponsiveness. Essentially, that asthma, bronchitis, and emphysema are all branches of the same genetic tree.
Wait, are they saying COPD is just adult asthma?
Okay.
Because that seems like a massive stretch.
Not exactly just adult asthma, but that a susceptible person's genetic makeup dictates how their lungs react to insults.
Okay.
So the environment, whether that's cigarette smoke or indoor cooking smoke, merely acts as the trigger that decides which specific disease pathway manifests.
I see.
And this debate actually echoes today in what we call the asthma-COPD overlap. We have patients who clearly present with features of both diseases, and it heavily complicates treatment.
How so? Like, what's an example?
Well, take inhaled corticosteroids. They are fantastic for reducing the specific type of eosinophilic inflammation you see in asthma. But if you give those same steroids to a patient with pure non-asthmatic COPD, they offer very little benefit and have actually been shown to significantly increase the risk of developing pneumonia.
Oh, wow. So everything really is interconnected.
Deeply interconnected.
Speaking of which, the sources spent a lot of time on something called core pulmonale. How does destroying the architecture of your lungs end up breaking your heart?
It comes down to a reflex called hypoxic vasoconstriction.
Okay.
In a healthy person, if a small area of the lung isn't getting oxygen, say, you have a tiny localized infection, the blood vessels in that specific area automatically constrict. This cleverly redirects the blood flow to healthier parts of the lung where oxygen is plentiful.
A great evolutionary defense mechanism, honestly.
Until the whole lung is damaged, like in advanced COPD.
Oh, no.
Right, because the entire lung is starved of oxygen. All the blood vessels reflexively constrict at the exact same time.
That sounds like a lot of pressure.
It creates massive chronic pulmonary hypertension. The right side of your heart is responsible for pumping blood into the lungs, and suddenly it's pushing against immense resistance. Over time, the right heart muscle thickens, strains, and eventually fails.
So the lung disease physically destroys the heart.
It does.
So if you're listening to this and wondering what your actual risk is, it means the risk factors are profoundly modifiable.
They are.
Whether it's choosing to quit smoking to stop that accelerated decline or focusing on global policy levels to provide clean cooking stoves to rural communities, the choices we make about the air we breathe directly dictate the structural integrity of our lungs.
And if we fail to modify those risks, the consequences cascade through the entire body. But, what makes COPD such a creeping tragedy is how incredibly gradually it progresses.
Let's quickly recap this journey because it really is staggering. We went from a missing protein band in a Swedish lab in 1963 to understanding that COPD is a two-front war. You have the plumbing problem of chronic bronchitis, where your airways are clogged with mucus and thickened by scarring. And you have the structural problem of emphysema, where an oxidized protein lets your own immune system go completely rogue, literally digesting the elastic scaffolding of your lungs and trapping air inside.
And one critical takeaway for anyone navigating this, an unremarkable chest x-ray does not mean you were in the clear.
That's a huge point.
Early to moderate COPD often looks totally normal on a standard x-ray. The gold standard is that spirometry breathing test, measuring your expiratory airflow, because it is fundamentally an expiratory problem.
The silent progression is what really gets people. When you start losing lung capacity, you don't necessarily wake up one day just gasping for air.
No, people are remarkably adaptable. You unconsciously change your life. You take the elevator instead of the stairs. You walk a little slower to the mailbox. You stop playing with your grandchildren in the yard.
You just adapt.
Exactly. Patients self-limit their physical activity so gradually that they never actually tell their doctor, I can't breathe. They just attribute it to getting older.
And this leaves the disease massively underdiagnosed. Millions of people meet the criteria for COPD years before they are officially diagnosed.
And by the time they are, that irreversible structural loss has already happened.
We've seen today how a single, tiny oxidized methionine residue in one protein can slowly collapse the architecture of your lungs over decades. It really makes you wonder what other microscopic silent battles are being won or lost in your body right now just by the air you breathe. And how will those invisible ledgers balance out 20 years from now?